Sayın Asoğlu söyledi. İlk 2 yılda %25 oranında tekrar büyüme riski var ve %7 de uzak metastaz. Peki bu durumda ne yapmak lazım? Endişelenmemiz mi gerekir? Son konuşmacı Doktor Paty'den bu konuyla ilgili konuşmasını rica ediyoruz.
Well, now I'm finally somewhat organized here. Thank you. This talk will be a bit of a provocative talk. It's the first time I've ever given it. I'm just still organizing the data. We're actually analyzing our data now for publication, and this is still something we haven't fully digested, but I want to talk about whether deferral of surgery, the potential of leaving cancer in the wall of the rectum for months or years, presents a risk for metastatic progression. This is a question I get asked when I give talks. I don't believe it does, but I think it's a legitimate question. So the data is far from excellent, but maybe we can frame the question and see sort of what the boundaries of the data are. So watch and wait. The goal, in my opinion, is local disease control and organ preservation. I don't think distant metastasis is it's an important endpoint, but I don't think it's one that's going to be easily interpreted without a randomized trial, which will never be done, in my opinion. Patients won't allow it. So if we could randomize patients and operate on half and not operate on half and have them randomly assigned and look at distant metastasis rates, that would be the study. We'll never have that study. So it'll always be indirect. So what does our data show about long-term local regional control, which we've already presented that, and we think salvage, the combination of the chemoradiotherapy and salvage surgery gives good local regional control, although not perfect. There are cases in our series and Sao Paolo series where local regional control is lost. Organ preservation, very good, not perfect. Distant metastasis, very complicated. So I'm going to try to address this question. Could there be a relationship? Here's the philosophy. This was a quote I just ran into a random reading, but this is a cancer biologist who actually works at Memorial Sloan Kettering. Makes the point that metastasis can appear at any time, out of the blue, sometimes after a protracted period of dormancy. My first cousin had a melanoma excised from her back at age 27. It recurred in her axilla at age 52, 25 years later. And she died of that disease 26 years later. So we know melanoma can do this. Colon cancer is not very common, but if we radiate these tumors, could we be putting the cells to sleep, but yet they still are threatening in some way? And by subsequent reactivation, which could, in this quote, governed by intrinsic programs, contextual cues, which means he has no idea, but somehow they wake up and they become dangerous. They don't die completely. So what would the concerns be about the data? Of course, the number of events, how many patients get metastasis, the length of follow-up, completeness of follow-up, are we losing patients to follow-up? And what we want to see is a convincing flattening of the disease-free survival curve where no more recurrences happen. I don't think our data has gotten to that point quite. So I'm going to look at briefly, very briefly, these three series. I could give a better talk next week, but I'll do the best I can. So this was the first really good granular presentation of the Sao Paolo data, which was published, I guess, 2.5 years ago, 2 years and a couple of months ago, where they really started with the number of patients who were irradiated, 183, and showed you all of the recurrences over time, not starting with the clinical CR or 1 year sustained, but starting in the beginning and looking really how do these patients do. And this is the flow diagram, and at this this paper, and my initial interest in this was on the local regional control. And I've taken this figure from the paper and annotated it with these red numbers where it shows how patients got to unresectable pelvic recurrence. And you can see this can occur with early regrowth, which they define as regrowths in less than a year after chemoradiotherapy. And there's 3 of them in the early regrowths out of 17 patients with early regrowth. Can also occur in late recurrence, which is after a year, and again, another 3, so equally divided. And you don't really get a lot of detail, but I get the sense that some of these were reluctant patients who were reluctant to have surgery. One was treated with brachytherapy, a couple were treated with local excision, some refused surgery altogether. And hard to know what the doctor was driving, what the patient was driving. But the bottom line is, in my estimate, there was not aggressive surgical salvage in all cases. And I think this is the potential harm of watch and wait, not salvaging aggressively. They published their data very clearly. You can see the blue curve is all the local recurrence. This is a fairly high local recurrence rate. Their initial paper said 3%, 4%, but that was the late ones. It's actually 28% of the initial clinical CRs have recurred locally. And of those, the yellow curve shows the proportion that were unresectable and eventually fatal. So watch and wait is dangerous if you don't salvage, if you don't follow. And I might add, their patients come from all over Brazil. It's hard to come back for follow-up. And I've talked to Rodrigo and Angelita about that. It's true. They have trouble getting some of their patients back for follow-up. At the Sao Paolo meeting a couple years ago, I looked at this data a little more critically, looking at the problem of loss to follow-up. If you look at the survival curves, they have median follow-up. This study was 5 years. Their follow-up was long, but it was anywhere from 18 months to 20 years. There's lots of censored patients. So looking at the events, if you look at local control, is their data really convincing that we have reported all of the patients who failed local control? It's pretty convincing that in the first 5-year period, where they had 27 local recurrences, all but one, they had 34 censored patients during that time frame, so roughly an equal number. Could have missed 1 or 2. But after 5 years, they only have 1 local failure and 24 censored patients. So that data is completely inadequate to document sustained local control. And I had a lot of fears about this, but over time, seeing my own patients and thinking about it, I'm less concerned, although I still think there's no long-term data. And again, would point out this blue curve. You see the events stretching out. There's a big drop-off in the first 2 years and then a flattening, but there's still events going on out to, in this case, out to 5.5 years. You can get a local regrowth. That's kind of frightening. Are we capturing the other ones? And yet, with this less than perfect local control data, that still their overall survival data and disease-free survival data look pretty good. These are reported for all of the clinical CR patients. Disease-free survival here, as best I could tell from this paper, includes the pelvic relapses, not the local regrowths, but the pelvic relapses. So my summary of their paper, which was very honestly presented, and I thought an excellent paper, was that their data wasn't quite as good as what we thought it was 10 years before when they first started reporting it, that local regrowths were dangerous, salvage was not always successful, and there are a lot of patients lost to follow-up. And that given the relatively small number of events, we're talking 28 regrowths, 6 local, these are tiny numbers, we really don't know whether these numbers are accurate in the larger picture and are generalizable. So more data is needed for the fate of clinical CR patients, certainly in the 5 to 10 year follow-up period. And I would conclude that they weren't perfect on their surveillance and surgical salvage. That's probably the biggest area for improvement, that if we're going to follow their lead, and they are the pioneers, they do have the most mature data, and they have set the standard, but I think we can do better with close surveillance. Now here's our data. This is what's called a swimmer's plot, and I apologize, it's going to be a little bit hard to see, but what this is the blue lines represent time from the completion of neoadjuvant treatment. This is the surveillance period going to the right, and we've ranked the patients from the shortest follow-up to the longest follow-up. And there's too many data points here. I would have made this differently. My colleague, Josh Smith, made this, but these are 22 patients, 21 or 22 patients, maybe I got it wrong. I think it's 22. I must have missed one. I think it's 19 on the left and 3 on the right. 22 patients with local regrowth, which are represented by these triangles. So this is the total follow-up, and this is the triangle shows when in time the local regrowth occurred. You can see very quick, 3 months. I had one of these a couple of years ago. I couldn't believe it. The guy came in, had a perfect exam, came back for his first 3-month checkup, tumor. And also charted here are distant metastases in the circular yellow. So you get it per patient data, and you can see most of the local regrowths, a lot of them are in the first year, nearly all of them are in the first 2 years. And again, I think these are cancers that are suppressed, not completely eradicated, and regrow. But then there's this, just like in the Haber-Gamma data, we're seeing the later regrowths. Our longest was 6 years and 3 months, my patient. 3 years and 4 months or so, another one a little over 2 years. So not many, only 3, but you know, how many more could there be coming? We don't know. And then you see there's a lot of distant metastasis here, and this really didn't become apparent to me until we started looking at the data over the last few months. So here we have 19 regrowths. I think I miscounted because there's 22 total. 19 regrowths, 3 distant recurrences in this time frame, but then there's more. Here's 1, 2, 3, 4, 5, 6, 7, 8 distant recurrences among 22 local regrowths. That's a pretty high number. And it turns out, when you look at the failure pattern in our series, most of the distant recurrences were associated with local regrowth. So we had 22 total, 14 were isolated, but 8 of them were associated with local regrowth, and only 3 were distant metastasis alone. And of the status of these patients, you can see 14 are NED, but the others are probably going to die of disease. 6 did, and 2 probably will. So that linkage is unexplained, and I'll speculate on that in a minute, but you can see that is certainly not true in the Girard's data, where he's got a lower overall local failure rate, but not that different. 15 out of 100 compared to 22 out of 113. It's not that different. They're using thousands of MRIs. I'm using no MRIs. It doesn't make that much difference. We do use MRIs. I'm teasing a little bit, but local regrowths are going to occur. I don't care how many MRIs you get. They're going to recur. But the Sao Paolo data is very similar to our data. When you look at it, there is this combination of failures. There's a higher number of failures, and there's a fair number of aggressive tumors that are metastasizing, and patients are dying of disease, and their disease-free survival, our disease-free survival, is almost the same in their series and our series. So not exactly concordant data, but interesting. And maybe there's some linkage of local regrowth and distant failure here as well. So I would summarize just crudely that the Girard's data shows slightly less local recurrence and dramatically less distant recurrence. 100, only 3. Here's 13, here's 11, and 3. That's 1/3, with almost the same follow-up. Not quite as long follow-up. And our data shows the linkage the strongest. And I'm just raising these as questions. So here's a few more data that I just pulled out of our data in the recent publications, the local regrowth rates are fairly similar. And again, I think it's obviously patient selection, how they're treated also, I guess, to some extent. Salvage is better in our series than the Sao Paolo series, but again, I think they had patients who refused aggressive salvage, which is one of the dangers. Most of them occur early, yes, across the board. Do late regrowths occur? Yes, Sao Paolo, yes, us. I don't know, Gerard, none yet, huh? Nothing beyond 2 years. Are there any clinical predictors of regrowth? Not in our series, not in the Sao Paolo series that they published. And I think Gerard has told me maybe tumor size predicts, but that's it. And then organ preservation rates are around 80%. So actually there is a lot of similarity, at least in the local regional, the distant metastasis, Sao Paulo and us are higher. So I'm just going to leave it at that I think that, I would also mention that when you do statistical analysis on the timing of local recurrence, the time to local recurrence does not predict distant metastasis. In fact, if anything, it's the early metastases that are associated more with local recurrence. If you really look at that chart, where are the distant metastases recurring? Most of these patients had local regrowth early. So I would argue this is bad biology. These are tumors that are regrowing quickly. They're resected within a year, but they develop distant metastasis because they're treatment resistant. They're radiation resistant, and they're chemotherapy resistant. So it's not associated with late regrowths. Late regrowths are probably a phenomenon, a very indolent disease that can be salvaged. So it's the early ones, I think, that are actually more dangerous. So our data shows association between local regrowth and distant metastasis. The events are few, possible bad biology, that maybe local regrowth and distant metastasis are both functions of just bad tumors. And maybe we get more of them because we're using total neoadjuvant therapy. We get some of these bad tumors to regress. Maybe that was Gerard's idea. That could be true. Is the deferral of surgery in any way causing these distant metastases? I think it's unlikely. You don't see it in association with time. And I think the only way to prove that would be a randomized trial, so it's difficult. And our distant recurrence rate is similar to the Sao Paulo data, so I don't think we're some kind of outlier. Gerard's the outlier. And we are going to look at this more deeply by taking these same cases and presenting them in the context of all rectal cancer patients receiving neoadjuvant therapy and look at the time course and the frequency of metastasis. And what you'll find is even though this looks like maybe this is bad, these patients are still overall doing well. There's still a 90% disease-specific survival at 3 to 5 year time frame. And I think you'll find that the time course of metastasis matches exactly that of patients who get resected up front. So this is just a natural history of the disease playing out and not deferral surgery, in my opinion. That's probably the best we could do. And we will be looking at this data in the future. Thank you.